Hello, we're back, and in this last video lecture, we're going to be talking about compliance coding and reimbursement. So let's have a look. Okay, we covered the UB04, otherwise known as the CMS 1450, and you can think of that as a claim form that's used for hospitals, SNFs, and anything else that's facility based, institutional based, right? And it also requires revenue codes. And these revenue codes classify what kind of institution this is, right? So is it intensive care? Is it emergency department? And so on. The 1500 is a universal claim form, and was developed by CMS and it's used by providers of all different types of services. And when we say providers, this could be physicians, this could be PT, anybody within scope. And they use these to bill professional fees, pro fees, if you will, to health carriers. And see a nice example of that in figure 10-5 of your book. And this illustrates a completed CMS 1500 form using ICD-10 CM codes. We also have some other things. Every employer has a national employer identifier, an EIN. All providers have a national provider identifier, or NPI. And all health plans have a health plan ID and a check digit as appropriate. When we use the term electronic data exchange, this is getting us into the 21st century. Prior to this, we would mail claim forms, we would fax them, all these different types of things. Now we have the computer to computer transfer of data between the physician office, if you will, and the payer. Sometimes these go to a clearinghouse, right, where they're all checked and validated to make sure all the fields are filled in. And they go into a data format that's agreed upon before the information is sent. The administrative simplification provisions of HIPAA had the federal government adapt national electronic standards for sending this data, right? And when we say sending the data, we're talking about data coming to the health plans, the payers, in other words, Blue Cross, Blue Shield, MOTA, whoever it is, and the providers. And we think of providers, this could be either the hospital or the physician's office in this case. So what does this do? It allows the entire healthcare industry to communicate electronic data using the same set of standards. So it eliminated all these non-standard formats that were formerly in use. And that way, a healthcare provider can submit a standard transaction for eligibility, authorization, claims, referrals, whatever it is, and it's all done in the same format. So you don't have to reinvent the wheel or worry about if the payer is using things in a different format. So this simplifies all these clinical billing and headaches we used to have where claims would be denied. However, electronic claims can't be processed if they're in any other format than the HIPAA format. Any provider or not small providers, in other words, organizations with less than 25 full-time employees, right, must send all claims electronically in the HIPAA format. So in other words, if a medical office chooses not to follow it, that is on them. Now we get into local and national coverage determinations, and this is a term you'll see before. LCDs and NCDs. What do these mean? Well, what these do is specify the special circumstances when a service is covered or not covered. And this assists providers, meaning hospitals, physicians, suppliers, in submitting correct claims. LCDs, in other words, local coverage determinations, outline how the contracts, in other words, the Medicare carriers, will review claims to ensure that they meet the coverage requirements. Contractors publish these LCDs to provide guidance to the public and the medical community in a geographic area, right? CMS publishes NCDs and requires that the LCDs are consistent with the national guidance. They can be more detailed or specific, and that's usually the case, right? So if you think about it, the national coverage determination by CMS, broad-based, the LCD fills in all the minutia, all the finer details. And these are developed with scientific evidence, clinical practice, and overseen by CMS and the Health and Human Services. There's certain never events or sentinel events. When we use the never events, these are errors in medical care that are identifiable, preventable, and serious. And these could be things like surgery on the wrong body part, foreign body left in the patient after surgery, medication errors, and so on. What Medicare is moving away from is requiring quality care. So, for instance, severe pressure ulcers that are acquired in the hospital, they used to formally pay for that. Now, if it's a big deal, they don't want to pay for it in the case of CMS. So that's why you see these flags that you'll see about in other um, courses where we talk about present on admission, the POA flags, if you will, right? So if it's present on admission and somebody's transferred from a SNF to an acute care hospital, yes, then CMS will pay the hospital for taking care of it. And if it's not documented, then CMS most likely will not pay for it. And this started with the Medicare Modernization Act of 2003, and it's continuing on for that. So with sentinel events, the differences between sentinel events and hospital terminology, we're talking about a never event with has the unfortunate outcome of somebody dying. We talked a little bit about this in the previous slide, and this is hospital acquired conditions. And these could be things not only pressure ulcers, but foreign objects retained after surgery, air embolism, blood transfusion mismatches, falls, trauma, catheter associated urinary tract infections, all these other different types of things. Hospital acquired conditions include those that are high cost, high volume, or both, and they result in the assignment of a case to an MSDRG that's a higher payment when present as a secondary diagnosis. The big question is, could it have reasonably been prevented through the application of evidence-based guidelines? And again, we have our old friend present on admission. CMS is now requiring hospitals to report on present on admission indicators for principal and secondary diagnosis. This includes external causes of injuries that are present at the time that the patient's admitted. And some of the things that these include conditions that develop during an outpatient encounter. So emergency department, observation, outpatient surgery, what have you. Where it intersects with our field, inpatient coders determine the present on admission indicator to be reported based on reviewing the documentation and the coding of the principal and secondary diagnosis. Now we get into something that is of interest to some people. This is fraud and abuse. fraud and abuse, these terms are used interchangeably. They're actually different things. Fraud is the act that is a crime against payers. It's misrepresenting, right? Abuse is a pattern of practice that's inconsistent with sound business, fiscal, or health services practice, which results in unnecessary cost, right? So fraud is basically trying to defraud the payer. Abuse is just inconsistent, expensive practice. Medical necessity requires the documentation of services and supplies that are proper and appropriate that are needed to diagnose and treat a condition. The Payment Error and Prevention Program identifies and reduces improper Medicare payments that results in a reduction in the Medicare payment error rate, right? So it's basically another cost control, if you will. There's civil monetary penalties under the Civil Monetary Penalties Acts. What this does is give the authority for financial penalties for a variety of healthcare fraud violations. The Office of the Inspector General has developed a series of provider-specific compliance guidance. These identify the risk areas and offer suggestions to improve and enhance an organization's internal controls so its billing and other business arrangements are following Medicare's rules and regulations. And CMS uses a four-part strategy on this. They look at prevention, early detection, coordination, and enforcement. One thing that you'll hear about in some other classes in our program is the National Correct Coding Initiative. And this was developed by CMS to promote, national correct coding methodologies and eliminate improper coding, right? The Federal False Claims Act, which goes back to the time of the Civil War, was originally intended to prevent people from defrauding the federal government during the time of war by overcharging and engaging in other fraudulent behavior. It was amended in 1986 to strengthen the law and increase monetary awards because now we don't only have military contractors, we have the federal government involved in our healthcare. The False Claims Act imposes civil and criminal liability on any person who knowingly submits or causes the submission of a false or fraudulent claim to the federal government. The federal anti-kickback statute prohibits the offer, payment, receipt, or solicitation of compensation for referring Medicaid and Medicare patients, and there's a fine per violation plus imprisonment of up to 5 years. There may also be civil penalties, and violators can be excluded from any government program, such as Medicare and Medicaid. So this gets people's attention. When we use the term safe harbor regulations, we're talking about various payment and business practices, although potentially capable of inducing referrals of business reimbursements under the federal health care programs would not be treated as criminal offenses under the anti-kickback statute, right? You can look at safe harbor as basically a kind of carve out, right? So safe harbor meaning an exception, if you will. Medicare Part A is the entitlement, if you will, right? And it's or healthcare facilities, meaning hospitals. And Medicare Part A reimburses healthcare facilities for costs that are associated with training residents. Residents being physicians who haven't fully completed their training. They tend to order more tests, have higher overall costs. And so the physicians at teaching hospitals, the PATH initiative, resulted from the discovery that some healthcare organizations were billing Medicare Part B for services that are already paid under Part A. Part B, of course, instead of the hospital, it is physician services. So if you're getting additional reimbursement for having residents, you can't get it again if your organization's been paid under Part A. Now we get into more interesting stuff. The Recovery Audit Contractor Program. And this started with the Medicare Prescription Drug Improvement and Modernization Act of 2003. This was created to find and correct any improper Medicare payments paid to healthcare providers that were participating in fee-for-service Medicare. These are basically collection agencies, so they would get a percentage of anything that Medicare overpaid to a hospital or a physician's office. Let's take a look at some of the different types of fraud and abuse. We'll start with abuse first. Abuse is billing a Medicare patient using a higher fee schedule rate than used for non-Medicare patients. It's a business practice. It's not on the same level as fraud, right? It's another example is submitting claims to Medicare when Medicare is not the beneficiary's primary payer, right? So it's not fraud in the sense that we're submitting claims for something that didn't exist. The patient has Medicare and another payer, but we're not submitting a claim in the correct order. Another example is submitting excessive charges for services, supplies, for things that are not medically necessary. In other words, big thing now with fee for service reimbursement is, was the service medically necessary? If it's not medically necessary, the payer may very well not pay it, right? So you can charge for it, right? It's not fraud because you're not misrepresenting anything, but it wasn't needed. So it's excessive, right? It goes back to that difference between fraud and abuse. And then violating the Medicare participation or assignment agreements. Now let's talk on the right side of the slide about it, fraud. Here's a big one, billing Medicare for services or supplies that you really didn't provide, right? So this is basically manipulation. It's fraudulent. You billed for something and you didn't honor your end of the contract, right? Another example would be entering another person's Medicare number on a claim to obtain reimbursement for a patient who wasn't eligible for Medicare. Again, misrepresenting. And then upcoding claims. We're seeing a lot of this in the fee-for-service world lately. And people are coding things up so we can work our way up towards higher reimbursement on the fee schedule, right? And again, this is fraudulent, right? The codes should map to the codes that are reported should be consistent with the documentation in the electronic health record. If we're just upcoding them, we're basically engaging in fraudulent activity. And then finally, we have unbundling codes. This means that we're assigning separate codes for a component that has a combination code. So we're unbundling it. Why? To make more money. A physician's self-referral law, or Stark 1, which is part of the Omnibus Budget Reconciliation Act, Reconciliation Act of 1989 prohibits a physician from referring Medicare patients to a clinical lab where they or a member of their family has a financial interest, right? This is a big, big deal, right? And then in 1994, because some providers routinely waived coinsurance and copayments, the OIG issued the following fraud alert. Routine waiving of deductibles and copayments by charge-based providers, practitioners, or suppliers is unlawful if it results in false claims, violations of the anti-kickback statute, or overutilization of items and services paid for by Medicare. Again, these are great definitions of what fraud really is. In 1995, the Stark II expanded on the previous Stark I by including referrals of Medicare and Medicaid patients for labs, home health, occupational therapy, parenteral and enteral nutrients, equipment, supplies, orthotics, radiology, CAT scans, ultrasounds, durable medical equipment, inpatient hospitalization services, outpatient medications, physical therapy, radiation therapy, and so on. So, in other words, if a physician had an interest in any of these services, now they own the practice or what have you, and they refer somebody to that, that is an issue and a violation under Stark 2. And that's all I have for you. Thank you so much for watching, and please reach out if you have any questions about any of this material. Bye now.